Welcome to the deep dive. If you're tackling your MSRA revision and maybe feeling a bit overwhelmed by all the information out there, well, you're in the right place.
Definitely. There's just so much to cover, isn't there?
Exactly. So today, we're doing a focused dive into acute myeloid leukemia, AML. We're taking your revision notes, essentially, and pulling out the absolute must-know stuff.
Yeah, the high-yield information. The aim is to make it stick, not just list facts.
Precisely. We want this to be a really streamlined guide, helping you get a solid grip on the core concepts of AML for effective recall. We're using MSRA revision notes as our base.
That's right. We'll cover everything from the definition, causes, risk factors, right through to how it presents, how we investigate and manage it, and what the prognosis looks like. We'll even try to throw in some memory aids where we can.
Fantastic. Shall we dive in then?
Let's do it.
Okay, first things first, let's get a clear definition. What exactly is acute myeloid leukemia?
Okay, so AML, it's fundamentally a cancer that starts right in the bone marrow. Specifically, it affects the myeloid cells.
And myeloid cells are the ones that normally become, what, red cells, some white cells?
Exactly. They're the precursors, the sort of baby cells for things like neutrophils, monocytes, red blood cells, and platelets. Crucial stuff.
Right.
But in AML, something goes wrong in their development. They get arrested, kind of stuck in an immature phase.
So they don't mature properly?
No, they don't. And worse, they start to overproduce massively. You get this flood of immature white blood cells, which we call myeloid blasts.
Oh, the blasts.
Yeah.
And the percentage is important, right?
Very. For most AML subtypes, the diagnostic threshold is having more than 20% blasts in the blood or the bone marrow sample. Used to be 30%, but WHO lowered it to 20%.
Okay, 20% blasts and other key features. It's mainly in adults.
Yes, it's the most common acute leukemia in adults. It can be primary, popping up on its own, or secondary, sometimes developing from a pre-existing condition like a myeloproliferative disorder.
And it's driven by genetic changes.
Fundamentally, yes. Abnormal gene activation due to various genetic hits seems to be the core issue. This leads to the blast overproduction, which then crowds out the normal blood cell production,
Causing problems like anemia and infections.
Precisely. And these blasts can also spill out and accumulate in other organs. And, with genomic advances, we're seeing just how genetically diverse AML really is. It's not one single disease.
Which brings us to classification. The notes stress this is really important. Why?
Well, it's absolutely critical for a couple of big reasons. First, the subtype tells you a lot about the likely prognosis, how the disease might behave.
Okay.
And second, it heavily influences treatment choices. Different subtypes respond very differently to therapies, so getting the classification right is key to getting the treatment right.
Makes sense. The notes mention two main systems, WHO and FAB. Let's start with the WHO classification. What's its approach?
The WHO system is quite comprehensive. It looks beyond just how the cells look under the microscope, the morphology. It incorporates genetic abnormalities, which are really crucial now.
Like specific gene mutations or chromosome changes.
Exactly. So one major category is AML with recurrent genetic abnormalities, things like specific translocations or inversions. These often define distinct subtypes with unique treatment implications.
Okay. What else does WHO consider?
It also looks at whether the AML arose from myelodysplasia, that's myelodysplasia-related AML, or if it developed after previous chemo or radiotherapy therapy-related AML.
So context matters.
Definitely. Then there's a category called AML, not otherwise specified, or NNAS, basically, for cases that don't fit the other specific genetic or context-based groups. It also includes myeloid sarcoma, where blasts form tumors outside the marrow, and AML linked with Down syndrome.
Right, so WHO is quite detailed, integrating genetics and history. What about the FAB system? M0 to M7 looks like classic exam fodder.
Yeah, it is. The French-American-British, or FAB system, is the more traditional one. It's based primarily on morphology, what the blasts look like, and how mature they seem.
Can we run through them quickly, maybe with those memory tips?
Sure. M0 is minimally differentiated. Think zero differentiation.
Okay, M0, zero differentiation.
M1 is without maturation, still very immature blasts.
M1, minimal maturation.
M2 shows with granulocytic maturation. You start seeing some development towards granulocytes.
M2, maturing granulocytes.
M3 is promyelocytic leukemia, or acute promyelocytic leukemia, APL. Very distinct, often has hour rods, and we'll come back to it. It's a big one.
M3, promyelocytic APL.
Got it. M4 is myelomonocytic, a mix of granulocytic and monocytic features.
M4, myelo and mono.
And M4EO is a variant with eosinophilia. The EO helps remember eosinophils.
M4EO eosinophils.
M5 is monocytic, M5A is monoblastic, less mature. M5B is monocytic, more mature. Think M5 monocytes.
M5 monocytic.
M6 is erythroid leukemia, involves red blood cell precursors. M6A includes erythroid leukemia. M6B is pure erythroid. Think M6 erythroid red cells.
M6 red.
And finally, M7 is megakaryoblast leukemia, precursors to platelet-producing megakaryocytes. Think M7 mega for megakaryo, related to platelets.
M7 megakaryo platelets. Great. That helps structure it. Okay, moving on to etiology. What actually causes AML?
Well, the notes are pretty clear that, frustratingly, the exact cause often isn't identifiable for a specific patient.
So not like a single trigger usually.
Not usually, no. But there's a very strong link to genetic mutations. These seem to be the key drivers. And then certain risk factors definitely increase the likelihood of those mutations happening or the disease developing.
Right, so genetic changes are central, possibly influenced by risk factors. Let's talk about those risk factors then. The notes list quite a few.
They do. We can group them a bit. There are treatment-related ones.
Like previous cancer treatments.
Exactly. Prior chemotherapy or radiation therapy are big ones. Interestingly, the type of chemo matters for latency. Alkylating agents, maybe 2 to 5 years later. For polymerase II inhibitors, sometimes much faster, like 3-6 months.
Wow, that's quick. What about chemical exposures?
Certain chemicals are implicated. Benzene is the classic one mentioned, and the notes specifically link it to the M6 variant.
Benzene and M6? Okay, worth remembering.
Then there's genetic predisposition. Conditions like Down syndrome significantly increase risk. A family history of AML itself also plays a role.
And other blood disorders.
Yes. Things like aplastic anemia, myelofibrosis, polycythemia vera, pre-existing bone marrow stress, you could say, makes it more vulnerable.
What else?
Chronic myeloid leukemia transforming into its blast phase, radiation exposure like the atomic bomb survivors, a historical cohort but proves the link.
Okay.
And then a list of congenital disorders. Bloom syndrome, Fanconi's anemia, congenital neutropenia, neurofibromatosis, all carry increased risk.
And lifestyle.
Smoking is definitely listed as a contributing factor.
So a real mix of things, past treatments, genetics, environmental factors, other conditions. It underscores the complexity.
Absolutely. It's rarely just one thing.
Okay, let's switch gears slightly to pathophysiology. What's the actual sequence of events inside the body once these abnormal cells start?
Right. The core process is that uncontrolled proliferation we talked about. These abnormal myeloid cells just multiply without the usual checks and balances.
And they build up in the bone marrow.
Exactly. They accumulate massively, crowding out the space. This directly suppresses the production of all the healthy blood cells, red cells, platelets, functional white cells.
Lead to bone marrow failure.
Precisely. Which causes many of the symptoms. Plus, these leukemic cells aren't always contained. They can infiltrate other organs, liver, spleen, lymph nodes, skin, even the brain sometimes.
So it's the dual problem of the marrow failing and the abnormal cells spreading.
That's a good summary.
Now, if someone presents with symptoms suggestive of AML, what else needs to be on the differential diagnosis list?
Good question. You absolutely have to consider other acute leukemias, primarily acute lymphoblastic leukemia, all similar presentation but different cell lineage.
Yeah.
Then myelodysplastic syndromes, MDS. These can sometimes present with low blood counts and blasts and can even transform into AML.
Right, MBS.
Chronic myeloid leukemia, CML, especially if it's presenting in blast crisis, can look like AML. Other myeloproliferative neoplasms, MPNs, need consideration too.
And other cancers.
Yes, other types of leukemias or even lymphomas can sometimes overlap in features, so you really need those bone marrow tests and specialized investigations to nail the diagnosis.
Definitely need to distinguish them. What about epidemiology? How common is AML, particularly in the UK?
Well, the UK data shows it's the most common acute leukemia in adults. We see around 3,100 new cases each year.
And mainly older adults.
Yes, it's more common as people get older. The median age at diagnosis is about 67. Actually, quite a chunk, over 40%, are diagnosed when they're 75 or older.
And the UK incidence rate?
It's around 4 cases per 100,000 people per year, which is noted as being relatively high compared to some other parts of Europe. So it's definitely a significant condition for us to manage.
Okay, so fairly common, especially in the older population. Let's talk clinical features. How does AML actually show up? What symptoms should make you think of it?
The symptoms often stem from that bone marrow failure we discussed. So general things like feeling really tired, weakness, that's very common.
Fatigue and weakness, okay.
Shortness of breath, often from anemia. easy bruising or bleeding like nosebleeds, gum bleeding, or heavy periods due to low platelets.
Bruising and bleeding.
Recurrent infections, because even if the total white count is high, the functional neutrophils are low. Bone pain can occur, pale skin from anemia, sometimes enlarged lymph nodes or spleen, and unexplained weight loss.
So quite a constellation of potential symptoms, many non-specific initially.
Exactly. But the combination, especially the rapid onset in some cases, should raise suspicion.
And these tie back to the specific blood count issues.
Yes. The anemia causes the pallor, the lethargy, the weakness, the shortness of breath. The neutropenia leads to the frequent infections. The thrombocytopenia causes the bleeding.
Makes sense. And splenomegaly.
Yeah, an enlarged spleen can happen due to infiltration by the leukemia cells, and infiltration of other organs can cause various specific symptoms depending on the site.
Does the presentation differ much by age?
It can do. The notes highlight that in children and younger adults, it's often quite acute, developing over days or weeks. Very dramatic sometimes.
Whereas in older adults.
It might be more insidious. Fatigue building up over weeks or months might be the main thing initially. And crucially, they might present with symptoms that look cardiovascular dizziness, shortness of breath, even angina or an MI, which can mask the underlying AML.
That's a really important point for diagnosis in the elderly. Any other specific symptoms to flag?
Fever is common, often from infection, and sometimes doesn't respond well to antibiotics initially. The bleeding can be severe, even life-threatening.
Right.
That enlarged spleen can cause abdominal fullness or early satiety. And if the white cell count gets extremely high, you can get leukostasis, a medical emergency, where the blasts clog small vessels, causing breathing problems or confusion.
Leukostasis emergency.
Got it.
What about examination findings?
You'd look for pallor, signs of infection fever, maybe chest signs of pneumonia, skin signs like petechia, purpura, bruises. You might feel an enlarged liver or spleen hepatosplenomegaly.
Lymph nodes.
Enlarged lymph nodes, lymphadenopathy, are actually less common in AML than in AL or lymphoma. Leukemia cutis skin infiltration is also uncommon but can happen. Oh, and swollen bleeding gums, gingivitis, can sometimes be a striking feature.
Gingivitis. Interesting. Now, you mentioned acute promyelocytic leukemia, M3, is special. What are its unique features?
Yes, APL or M3 really stands out. It's strongly associated with that specific translocation, T1517, creating the PML-R-alpha fusion gene.
Okay, T1517.
It tends to affect a slightly younger group, average age around 25. Morphologically, you often see those hour rods, distinctive needle-like granules in the blasts.
Our rods in M3.
And clinically, it's notorious for causing disseminated intravascular coagulation, DIC, and severe thrombocytopenia right at presentation. Major bleeding risk.
But the prognosis?
Despite the dramatic presentation, the prognosis is actually much better than most other AML subtypes, largely because we have very effective targeted treatments now, like ATRA and arsenic.
That's a key distinction. Okay, so how do we confirm the diagnosis? What investigations are essential?
It starts with blood tests. A full blood count, FBC, is obviously key. You'll typically see anemia and thrombocytopenia. The white cell count is variable, could be high, low, or normal, but there are usually blasts present on the blood film.
Right, FBC and film.
A clotting screen is vital, especially looking for DIC, particularly if you suspect M3. LDH is usually elevated due to high cell turnover.
LDH, okay.
Liver and renal function tests are needed for baseline before chemo. Electrolytes too, potassium, calcium, magnesium can be abnormal, especially in M4, M5 subtypes due to cell lysis. And infection workup if they're febrile.
Blood tests give clues, but the definitive diagnosis comes from?
The bone marrow aspiration and trephine biopsy, that's the gold standard.
That's where you look for the 20% blast.
Exactly. You need that for the formal diagnosis in most cases. We also do HLA typing on the patient and potential family members if they might be a candidate for an allogeneic stem cell transplant later.
Makes sense. And specialist tests on the marrow.
Yes. Cytochemical stains help with the FAB subtyping. Flow cytometry is crucial for identifying cell surface markers, confirming the myeloid lineage, and helping classify tricky subtypes like M0 and M7.
Flow cytometry.
And then cytogenetics, looking at the chromosomes, and molecular tests like FH or PCR to find those specific genetic abnormalities like T1517 or FLT3 mutations. These are vital for prognosis and guiding therapy.
So morphology, flow, cytogenetics, molecular tests, a whole panel. Any imaging needed?
Usually a chest x-ray to check for infection or heart size, and often an ECG and maybe a MUGA scan or echo to assess heart function before starting potentially cardiotoxic chemotherapy.
Right, baseline cardiac assessment.
Okay.
Diagnosis confirmed, AML classified. How do we manage it? What are the main treatment pillars?
The mainstays are chemotherapy, sometimes stem cell transplantation, increasingly targeted therapies, and absolutely crucial supportive care.
And it's individualized.
Highly individualized, based on age, overall fitness, the specific AML subtype and its genetic profile, and patient preference to some extent. The goal is usually to achieve remission.
Which means?
Getting the blast count in the marrow below 5%, restoring normal blood cell production, and having normal peripheral blood counts. Treatment usually happens in specialist centers, often within clinical trials if possible.
The notes talk about induction and consolidation phases.
Yes, induction is the initial intensive phase of chemotherapy. The aim is to kill off the bulk of the leukemia cells and get the patient into remission. Classic regimens often involve cytarabine plus an anthracycline like daunorubicin. Sometimes a targeted drug like gemtuzumab ozogamicin is added for certain subtypes.
Okay, intensive induction, then consolidation.
Right. Once remission is achieved, consolidation therapy is given to mop up any residual leukemia cells and reduce the risk of relapse. This might involve more cycles of chemo or potentially stem cell transplantation.
Tell me more about the stem cell transplants, autologous versus allogeneic.
So an autologous transplant uses the patient's own stem cells, collected during remission and given back after high-dose chemo. An allogeneic transplant uses cells from a matched donor sibling or unrelated.
And the choice depends on?
Many factors: risk category of the AML, patient age and fitness, donor availability. Allotransplant offers a potential graft versus leukemia effect where the donor immune cells fight the AML but has risks like graft versus host disease.
So it's a complex decision.
Very. The notes suggest overall survival can be similar between chemo, auto-SCT, and allo-SCT in some groups, but allo-SCT might be better for higher-risk disease or if there's still evidence of minimal residual disease, MRD, after chemo.
And what about APL-M3 treatment again? You said it was different.
Yes, APL is treated primarily with targeted agents, all trans-retinoic acid, ATRA, and arsenic trioxide, ATO, often with some chemotherapy alongside. These drugs force the promyelocytes to mature, overcoming the differentiation block. It's transformed APL outcomes.
That's amazing. And supportive care sounds vital.
Absolutely essential. Managing infections aggressively with antibiotics, transfusing red cells and platelets as needed, managing complications like DIC, especially in APL, careful attention to bleeding risks, avoiding unnecessary invasive procedures.
What about managing high white counts?
Allopurinol is often given to prevent tumor lysis syndrome during chemo. Leukapheresis, filtering out white cells, is generally not recommended routinely in AML, though it might be considered in specific hyperleukocytosis emergencies, potentially in APL.
Okay. And any maintenance therapy?
Yes. The notes mention NICE recommends oral azacitidine as maintenance for some patients in remission after chemo, as it's been shown to extend survival in certain groups.
Right. So a multi-pronged attack. Let's talk prognosis. It sounds like it varies a lot.
It really does. As we've said, factors like age, general health, the specific genetics of the leukemia, and the response to initial treatment all play a huge role. AML is aggressive, relapse risk is significant.
What are considered poor prognostic features?
Older age, definitely say over 60. Having residual disease, like 20% blasts after the first cycle of induction chemo. And certain high-risk cytogenetic abnormalities like deletions involving chromosome 5 or 7.
And survival rates generally.
Better for younger patients under 65, partly because they tolerate intensive treatment and transplants better. The overall 5-year survival for adults is still quite low, maybe around 17% quoted here, largely because progress in older patients has been slower.
But better in children.
Much better in children, yes. 5-year survival is now up around 65–75%, a real success story compared to adults.
And specific genetic markers for prognosis.
Yes. Favorable ones include T821 in V16 and that T1517 in APL. Mutations in NPM1 without FLT3 ITD are also generally favorable.
Unfavorable.
FLT3 mutations, especially the ITD type, are generally unfavorable. Complex cytogenetics are bad. And as mentioned, older age, very high presenting white count, secondary AML, SAML, or therapy-related AML, TAML, and CNS involvement all tend to worsen the outlook.
So genetics are really key for predicting outcome. Lastly, what are the main complications patients might face?
Infections are a huge one due to the neutropenia from the disease and the treatment, bleeding risk from low platelets, profound anemia.
What about organ damage?
Yes, potential damage to liver, kidneys, or heart from the leukemia infiltration, or, importantly, from the side effects of chemotherapy. Long-term, there's an increased risk of developing other cancers later on.
And the psychological impact?
Absolutely massive. Dealing with the diagnosis, the intensive treatment, the uncertainty. It poses huge emotional and psychological challenges for patients and their families.
It's clearly a very tough diagnosis. But this has been a really helpful run-through of the key points from the revision notes.
I hope so. We've covered the definition, the classifications like WHO and FAB. Remember, M3APL is special. The risk factors, how it affects the bone marrow, what else it could be, the UK stats, the symptoms and signs.
The crucial investigations like bone marrow biopsy and genetics, the treatment phases with chemo and transplant options, the variable prognosis factors, and potential complications.
Exactly. Hopefully breaking it down like this helps it all sink in for your revision.
And if you need a refresher on any part, you can always listen back. For more revision resources, do check out PassTheMSRA.com.
And freemsra.com as well, both great resources.
Definitely. So, a final thought, perhaps.
I think it's just that the understanding of AML's genetic landscape is moving so fast. This is constantly refining how we classify it, predict outcomes, and develop new targeted therapies. It really emphasizes the need for ongoing learning in this field. Things are changing, hopefully for the better.
A field in constant evolution. Well, thank you for that comprehensive dive into AML, and thank you for joining us on the deep dive. Until next time, goodbye.